So we're seeing more metastatic disease now on the more sophisticated, these molecular targeted imaging, if you will, scans that we're doing. And so it does change, I think, what we do. We're finding now that this biochemical recurrence space is probably shrinking. This actually is more metastatic castrate sensitive. And we're seeing these low volume metastatic castrate sensitive patients. And are any of you doing metastasis-directed therapy for those patients? Yes. and trying to maybe even avoid some of the complications and side effects from ADT and the ARPIs?
I think one of the issues with PSMA PETs is that you get the stage migration where you can find these patients earlier. We know from Stampede that offering even low volume patients radiation early on was associated with improved overall survival. So when we use it, we have that discussion at Tumor Board, and we do try to get patients enrolled in trials such as the Extend trial that offered radiation to patients with oligometastatic disease, less than 5 sites. So yes.
Scott, just to follow up on it, the survival for patients with metastatic prostate cancer is increasing. So the quality of life issue becomes important. So being on ADT for extended period of time is not as much fun for most patients. So stereotactic radiotherapy to oligometastatic disease helps us to hold off on that ADT for a little while longer. So that's another discussion we have with patients as well.
Yeah, I mean, Chris, you see a lot of people on ADT. Do you ever have anybody come in and says, "I want more ADT"? I mean, it's a problem, and it's more than just the hot flashes. But we know about bone health. We know about the cardiovascular risks. Even patients that just have prostate cancer in general are higher risk. So how do you handle that in your practice?
Yeah, no. To answer the first part of the question, no one's ever come in and said that. It can have quite a few side effects. It can be quite debilitating for some patients, and I think keeping that in line with our goals of treatment and goals of care is very important. I think offering intermittent therapy where we're able to can help ameliorate some of those side effects. I think in encouraging regular weight-bearing exercise, encouraging calcium and vitamin D supplementation, making sure these patients are getting their DEXA scans, periodically, and getting them the appropriate treatment when you see things on there. I think those are all the things that we should be doing when these patients are on ADT to try to prevent side effects related to treatment and try to minimize symptoms related to it.
All right. Well, let's take. Oh, sorry. Go ahead.
I'm sorry. I was just going to say, following on Chris with regard to bone therapy, one of the other things that we do is, in addition to getting DEXA scans and all that, we also put them on bone-preserving agents such as denosumab or zoledronic acid, and we use the once in 6 month regimen rather than do the once in 3 weeks or monthly, and that's based on the study that it preserves. It slows down the deterioration of bone on ADT. So that's another strategy that we could use to keep the cost and the side effects to the minimum, but still help with the bone health.
I'm curious how many of you guys are doing that are strictly for castrate-resistant disease, or are also metastatic castrate-sensitive as well?
You mean the bone preservation? Mm-hmm. Yeah, because I do the 6 month regimen. I do it on anybody I start with ADT as long as they don't have any contraindication. I prefer to do the denosumab, the Prolia, because it's given subcutaneous, and we don't have to monitor the creatinine. But one thing we have to be careful is that they are not planning to have any dental work, or they don't have any dental issues to minimize the risk of ONJ.
We do it on a risk-adapted basis based on their DEXA scan. I don't do it routinely for all patients.
Well, let's take a step back, and we can even talk about the newly diagnosed high-risk patients first. And we know now that we have some guidelines in terms of some biomarkers and looking at testing on that. So how are you incorporating germline and somatic testing now into our treatment algorithm? Because we know that we are moving more toward precision medicine. The days of shotgun therapy. And as a medical oncologist, cytotoxic chemotherapy works, but it also kills a lot of the good guys too. And so we're moving more toward precision medicine. Prostate sort of lagged behind breast, but we're catching up. But what can we do now with these patients based on guidelines? What options do we have in terms of testing now? So let's talk a little bit about that.
So we know that in hormone-sensitive prostate cancer, there's not much of a treatment-based role depending on the genetic profile. I use it to basically risk stratify my patients, and it helps me to have an educated conversation with them to tell them this is high-risk disease or low-risk disease. And so to be more specific, we know that there are mutations that predict more rapid progression to hormone refractory disease, examples being PTEN, RB1, TP53. And so if we have that data early on, then it allows us to basically set realistic expectations for the patient. It's not so much with treatment intent, more so with prognostic intent upfront.
Right, well, so there's biomarkers that can help us with familial tendencies, prognostic tendencies, and predictive tendencies as well. And it's really the predictive aspect of it that's really just opened up significantly now. And even in the newly diagnosed high-risk patients now, the NCCN guidelines are pretty clear that those patients should get germline testing as well.
Yeah, germline testing, I would say, has become part of, one of the first things I talk about when they come back to go over their biopsy. So if they have high risk or unfavorable intermediate risk, I talk about that at their first visit and kind of put that in their brain to think if that's something they want to pursue. And then on top of that too, I think I'll use a lot of the genomic testing from the prostate biopsy samples to help further risk stratify, whether that's helping to determine length of ADT when you're going to give radiation, considering somebody for active surveillance. So I think we have a lot of options there when it comes to additional genomic testing to sort of risk stratify these patients.
And just to follow up on what I've said is one of the other mutations I look for when we do somatic testing is the PARP mutation. These patients don't seem to respond to ADT quite well for a prolonged length of time. So, one of my roles, anybody with high-risk prostate cancer or metastatic prostate cancer and tissues available, we go for somatic testing. And we go for, if the somatic testing is suspicious for germline mutation, we can pursue it a little bit more. And most of our somatic testing, at least our institution, they look at over 500 genes, and it's pretty comprehensive. And then if we save that data for future use for therapeutic purposes. But at this moment in time, we are collecting this data. As you said, there's really no therapeutic strategy, so to speak. And with regard to prognosis, other than PARP, others are useful, but not critical in the management in the early stage of the disease.
And then, of course, many of these patients with high-risk disease are getting imaging now. They're getting molecular targeted imaging for PSMA. And I think it's important for our audience to understand that not everything that you see on a PSMA scan is prostate, because there can be false positives. Have you seen that? And if you have, because I know that we've actually diagnosed a couple of lung cancers in patients that came in with prostate cancer. And oh, by the way, there's a couple lung nodules, and biopsy wasn't prostate cancer, even though it turned up hot on the PSMA.
It's a great test, but like all good tests, it has limitations. I think the false positives are usually seen in benign conditions of fractures. You can see it in hemangiomas, Paget's disease. We know that certain malignancies, RCC, glioblastomas, very vascular malignancies, will also occasionally give us false positives. And that underscores the importance of looking at the entire clinical picture as well.
Yeah, the other thing is, neuromas and neural tumors tend to be positive, and that's particularly important when we're evaluating lymph nodes and the presacral area and all that. You could have an uptake, and so if it's an unusual uptake or an isolated uptake, we just need to think of false positives as PET CT.